Good evening, and welcome to AUA's Global Perspectives in Urothelial Carcinoma, Japan-focused webinar. The webinar is presented by the AUA in partnership with the Japanese Urological Association, JUA, and we strive to offer outstanding educational courses. We greatly appreciate your evaluations and general feedback so that we are able to continuously improve our programs. The AUA is accredited by the ACCME and designates this internet live activity for a maximum of 1.5 AMA PRA Category 1 credits. Course handouts from the presentations have been made available to you. Please visit AUA University to access the handouts. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on AUA University immediately following the webinar. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format following this program. All persons in a position to control the content of the AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit the AUA University to view Faculty and Education Council disclosures. The AUA would like to thank Astellas and Pfizer Incorporated for providing an independent educational grant in support of this webinar. Coding advice given during presentations are the opinion of the presenters and may not have been vetted through AUA for accuracy. Please verify accuracy prior to reporting on medical claims. Please note that course participants are prohibited from using or uploading content you access through this activity into external applications, bots, software, or websites, including those using artificial intelligence technologies and infrastructure, including deep learning, machine learning, and large language models and generative AI.
Hello, everyone.
I would like.
Oh, sorry. Go ahead, Lacey.
I would like to extend a special thank you to our course directors and content creators, Dr. Broneman and Dr. Shariat, for their time, talent, and expertise in developing this program. Finally, I would like to extend a special thank you to tonight's moderators, Dr. Sam Chang and Dr. Matatoshi Ito, and the rest of our regional faculty panel for their time, talent, and expertise tailoring the program for tonight's Japan regional audience. It is my pleasure to introduce Dr. Sam Chang. Dr. Chang is a Patricia and Rhodes Hart Chair of Urology at Vanderbilt and has worked extensively with the AUA and the NCCN and bladder cancer guidelines for the past 15 years. I will now turn the webinar over to you, Dr. Chang.
That is obviously needs-based and focuses on significant learning objectives. And these are ones that we've discussed and we'll focus on overall looking at our treatment of urothelial carcinoma. These are the specific learning objectives outlined. And it's with great pleasure that I'll introduce my co-moderator. I've been quite fortunate to develop relationships with many of our Japanese colleagues over time, and it's with great honor that I present and introduce Professor Ito, who will now be on screen. Professor Ito is the chairman of the Department of Urology in the Graduate School of Medicine at Kyosho University. His special interests include the diagnosis and treatment of urologic cancers, as well as tumor immunology and urologic surgery. He is the immediate past president of the JUA. He will be introducing the remainder of the panel that we've had the privilege to work with. So, Professor Ito, thank you so much for your past contributions and look forward to today's discussion.
Thank you, Professor Chen, for your kind introduction. I'm Professor Masatoshi Eto from Kyushu University, Japan. It's a great honor for me to have a chance to moderate this wonderful webinar session. I would like to introduce Japanese panelists. First, Dr. Hiroshi Kitamura, Dr. Kitamura is a GU oncologist, professor in the Department of Urology, University of Toyama, Japan. He is not only a board-certified urologist by JUA, but also a board-certified medical oncologist by JASMO. He is now the chair of Urologic Oncology Study Group in JCOG. Second panelist is Dr. Junichi Inoguchi. Dr. Inoguchi is a professor and chairman of Urology, Graduate School of Medicine, University of the Ryukyus, Okinawa, Japan. He specialized urologic oncology, particularly urothelial carcinoma. He is also an expert in various robot-assisted surgery and laparoscopic procedures. Third panelist is Dr. Shugo Yajima. Dr. Yajima is a urologic surgeon at the National Cancer Center Hospital East with expertise in robot surgery for urologic malignancies. His work combines clinical practice in minimally invasive surgical techniques with research on perioperative care optimization for elderly cancer patients. So we'd like to move on the first segment. Please, Dr. Chan, please start.
Thank you so much, Professor Ito. We're going to start off with looking at risk, defining risk, looking at staging and understanding that the biology is influencing what decisions that we're making, ctDNA, molecular subtypes. I want to ask the group, are you using these types of markers up front, types of imaging, molecular imaging, et cetera? How much do you use them in terms of making your decisions regarding treatment?
Dr. Chan, in Japan, maybe molecular staging is, of course, very important. We should change treatment strategy according to the molecular subtype, for example, luminal or basal. But in Japan, we don't use such strategy. It's very restricted. And also, NGS is covered by national insurance only for patient or standard treatment failure. So, and it's a little bit difficult in Japan.
What
PET
about
CT is, yeah.
what about PET CT or MRI?
Yeah, these are also difficult, quite restrictive, especially PET CT. So we prefer use MRI for assessment of pelvic lymph node status. So the answer for the discussion anchors, should PET CT replace CT bone scan as standard, is maybe we need to say no in Japan. It's a little bit far.
What about these kind of molecular biology tests that we talked about? The ctDNA is very hot, molecular subtyping, the basal versus luminal. What's going on now in Japan regarding these? You mentioned that it may not actually be covered.
Yeah, it's not covered. Insurance only after all standard therapy fail. So it's a little bit slow comparing to in other countries.
Well, let's move on. Let's think about, okay, well, we're trying to determine the best patients. For a long time, it was just platinum-based chemotherapy, and we try to determine who was platinum eligible, who's not. Well, now with this combination of EV Pembro, we've got on the slide, is platinum eligibility, is that still really important when we look at patients with bladder cancer?
So for using EV Pembro combination, so the cisplatin eligibility is no longer the key driver, and I think the now major decision drivers are patient goals and communities and the molecular profile results. But for other regimens, especially the cisplatin-based chemotherapy, the cisplatin eligibility remains a key driver, and the Galsky criteria included creatinine clearance higher than 60 and equal performance status 0 and 1, and no neuropathy and no hearing loss. But neither trial used the creatinine clearance higher than 40. So the shift in thinking towards broader cisplatin eligibility. So in addition, the Freddy scores and the geriatric assessment. So these tools increasing guide decision making in elderly and frail patients.
Well, I think, those characteristics are really important as we think about platinum, but now we've got this EV Pembro combination that,
Yeah.
shows incredible, overall survival, progression-free survival
Yes.
changes. I think that from that standpoint, if we look at EV Pembro as a new standard, I'm going to pick a little bit on now Professor Kinemura. If we look at that, what drives your choice? You've got a lot of things to think about, this overall survival, the side effects, the cost, etc. Tell me kind of your thoughts regarding this combination therapy.
Yes, we Japanese urologists and medical oncologists often choose EV Pembro as a standard treatment for first line treatment because PFS and OS of the pivotal trial are quite good. But I actually recommend chemotherapy when patients have systemic skin disorders or are contraindicated for immune checkpoint inhibitors.
So along those lines, Dr. Yajima, I'm gonna pick on Dr. Yajima. Dr. Yajima is the youngest. He doesn't have gray hair like me. So tell us a little bit about the mechanism of EV Pembro. How does it work? Why does it work?
It is said that combination effect of EV and ICI. EV has a bystander effect, which directly to deliver a cytotoxic agent to cancer cell, and combination of the different mechanism will be effective.
Right. So EV is obviously targeting. It's an antibody drug conjugate, targets nectin.
Yes.
The pembrolizumab
Yeah.
is a form of immunotherapy. So that combination obviously has had.
Yes, for combination, I think that there is a synergetic effect by EV Pembro combination, and some preclinical studies showed the synergetic effect as anti-tumor activity.
Yeah, I agree with that.
Yeah, let's go on.
Yeah.
This to me is always the difficult question is we've got obviously everybody's flocking to EV Pembro. What happens after EV Pembro? Not everybody responds. Where do we go next after EV Pembro?
It's very difficult in Japan, and maybe also similar to other countries, very challenging. And if patient is positive for FGFR3 mutation, in Japan we can use elafibranor from just this summer. So if the patient positive for FGFR3, we can use the elafibranor is one of the option. But in the real world, I will recommend patient for clinical trial enrollment because in Japan, there are not so many approved options. They're so limited. So I will recommend for clinical trial enrollment if eligible.
Well, let's talk about, again, trying to figure out the best patient. What should we do? How do we figure it out? You had mentioned that next-gen sequencing is really not done that often. But if you had that capability, one of you tell me kind of how would you use it? What would you do? I know it's not commonly available, but it's very hot topic. So tell me your thoughts.
So the in United States, the baseline NGS for FGFR3 and HER2 and MSI high and TMB high, so it's available. But in Japan, the NGS only covered by insurance after standard treatment, so we cannot do that. So currently, we can do the companion test for the MSI high. These are for the pembrolizumab and the FGFR3 alteration for the adaptation. So we only do these tests only.
Well, if we go ahead and look at these combination therapies, Professor Noguchi, if we look at that, currently there's no question that multidisciplinary approach is very important. So for you, who gets perioperative immunotherapy at this point? We've got a variety of studies. It looks like not a lot of insurance coverage in Japan. Tell me a little bit about your use of adjuvant or neoadjuvant IO.
Okay, so in Japan, the durvalumab plus GC regimen, so by the Niagara trial, is just approved several days ago. So we will use, and this regimen will available in the near future. But now in our current actual practice is not available. We only use adjuvant nivolumab, and no neoadjuvant IO. So currently we will perform the neoadjuvant chemotherapy, and adjuvant IO is a standard treatment.
So along those lines, we have perioperative care, and now there's a real interest in bladder preservation, a combination of therapy, and increasingly there are going to be more patients. There are more patients that get what we call a CCR, a clinical complete response. So tell me a little bit in those patients that get an evaluation, and it looks like, boy, the systemic therapies really cleared things up. Kind of tell us your thoughts regarding what to do next.
In case if I want to recommend bladder preservation if the situation is fit for preservation. In Japan, moderated therapy with TRBT and radiation and chemotherapy is often performed. But ctDNA clearance is also useful for the assessment. But maybe we should be careful because Niagara study reported the patient with clearance of ctDNA and pathological after durvalumab treatment, also recurrence after radical cystectomy. So we should be careful. But for some patient, it's very good option to bladder preservation is very good option. I think so.
Yeah, no, I think you raised a really good point. We're not accurate enough, I think, at this point to leave the bladder alone. So I think with any bladder preservation, we still need to think about localized therapy. At this point, it's still either bladder removal or radiation or combination. I don't think we're good enough to not do anything to the bladder. Maybe we'll get to that point. But if we think about another scenario, more advanced, clinically node positive disease, this is a patient obviously that instead of having a complete response tumor going away, we still have node positive disease. Tell us, what you think about, what to do next. What do we do with these node positive patients? Anyone? What do you guys do? I mean, maybe at this point we really don't know. I mean, it's difficult. You've got,
Yeah.
I mean, you've got so many things going on. It's unsure that
Actually, there is little data or evidence to provide a clear answer to this question. Cystectomy may also be performed to alleviate symptoms such as hematuria, pain, prosuria, parachysuria, and dysuria. There may be situations where surgery is undertaken even if ctDNA is positive.
Yeah, I think that's a good point. I mean, we're getting to the point where we continue to make inroads. We understand that we've gone from platinum-based to combination therapies, multiple combination therapies, and evaluating response. So we really, at this point, we've got a new standard. Whether or not we know exactly when and how to use it, I think is the most difficult question that we'll continue to need to study. So I'm going to turn over at this point and have Professor Ito do a little work and lead us through another a few segments here. So Professor Ito, I'll turn it over to you.
Can you hear me?
Now I can hear you.
Thank you.
Not yet? You can hear?
Yeah, I
Okay.
can hear.
Okay. Previous slide, please. Okay. Okay. I'm Professor Masatoshi Eto. I will moderate segment 2 and 3. The topic of segment 2 is delivering holistic multidisciplinary care to UC patient. Treatment choice are no longer linear. Surgery, perioperative IO, ADCs, trimodal therapy, ctDNA guided follow-up, palliative integration. Patient needs the right expert at the right moment. Let's define what optimal team-based care looks like in 2025 and who should read it. So, first topic is who leads care in locally advanced or metastatic UC and why. In your system, who is the default care lead for locally advanced or metastatic UC? Urologist, medical oncologist, or a rotating chair? And what makes that model work?
Yeah, actually, in most hospitals in Japan, urologists deliver systemic therapy, like German-speaking regions. Also, urologists lead in bladder preservation and palliation. Leadership may not shift with treatment phase in Japan. In all phases, urologists are leaders.
Yes, this is probably, I think, Japan and German speaking region specific. So, and so basically, leadership rotate. We do not rotate leadership in Japan. Okay. Next topic is multidisciplinary team composition. So, what voices must be in the room for MIBC, locally advanced, or metastatic UC? And when do you convene them?
So the the urology reads almost all procedures and therapeutic planning. So, but we need the help of the medical oncologist and the radiation oncologist and radiologist and pathologist, and also the nurse navigators. The best practice for these multidisciplinary team should be start at the earlier, I think.
Okay. If you could add one overlooked seat to your MDT tomorrow, who would it be?
For me, the nurse navigator.
Nurse navigator.
Yeah,
Okay.
much helpful for us.
Okay. Yeah. I think it's also a Japan-specific situation. Thank you. And next topic is radiation oncologist seat at the table. Are we using trimodality therapy, TURBT plus chemoradiation? And where should radiation oncologist lead?
I think basically trimodal therapy should be led by urologists because we need to perform cystoscopy, and in some case we need to biopsy using TRBT. So basically, urologists should lead. But in some situation, of course, radiation oncology are essential, and we need to shake hands and treat together. It's important, I think so.
Yeah, so in this sense, so who should trigger TMT workup? Urology or radiation oncologist?
Yeah, so the answer is I think Rogers should take leader
Yeah,
in
of
this,
course.
especially in this situation.
Yeah, in Japan,
Yes.
it's also Japan specific, and of course we need to sometime consult to radiation oncologist from
Of
us.
course. Yes.
Okay. Next topic is perioperative IO and ctDNA. Who decides on perioperative IO or EV pembro, and how do we integrate ctDNA?
In Japan, many institutions, most of institution urologists decide choice, and I find some mistake in this slide. In the red character, not yet available in Japan, is now available. Durvalumab and GC is now available. Maybe just 1 week ago, I think so.
A few
This
days
is
ago,
like
probably.
a few days. So
Yeah.
this slide had some mistake. Yes.
Okay, and should ctDNA positivity automatically trigger adjuvant IO?
Maybe it's difficult. Maybe it's controversial. In Japan, the Altair study linked to the Circulate Japan project suggests that ctDNA guided adjuvant therapy looks encouraging. That results were presented on this ASCO this year. However, I think it's still controversial. It's very difficult. I think definitive evidence to make ctDNA positivity an automatic trigger for adjuvant therapy is still lack for evidence. For
Yes.
now, I think.
Yes. And in Japan, probably we do not have to, check ctDNA before using adjuvant nivolumab.
Yeah,
Okay.
yes.
Okay. Next topic is survivorship ownership. After curative therapy, who owns survivorship in Japan?
In Japan, almost all cases were owned by a urologist. I think.
Yeah, almost I agree.
Yeah.
Okay. And so transition, survivorship be MDT led or transition to primary care office-based urologist? There is no such transition in Japan.
Yeah, no such urologist. But
Oh,
in the future, we also make this transition is better because too much work for us.
okay. And next topic is high volume centers. Should all advanced UC cases be referred to high volume centers?
Yeah, I think that this is a little bit difficult question to answer, but I agree with that we should all advanced UC cases be referred to high volume centers because it is well known that the incidence of complications and perioperative mortality rates following radical cystectomy are lower in high volume centers. I believe that high volume centers are also better equipped to manage side effects and adjust treatment schedules for a wide range of medical treatments, including not only chemotherapy but also immune checkpoint inhibitors and antibody conjugates.
Okay, so would mandatory referral improve equity or limit access? How do you think?
I would say I would say
Yeah.
mandatory referral is I think it's important, but yeah, improve it.
Yeah,
Equip,
it would
yeah,
it would
yes,
be better, probably.
yes.
Okay, thank you very much. So I would like to wrap up this segment too. Multidisciplinary care isn't a meeting. Clear leadership, predefined handoffs, and shared pathways are important. When we choreograph that well, patient feel one team and feel one team, not three clinics, and outcomes follow. Thank you. So I'd like to move on to segment 3. Topic is incorporating guideline into practice. Guidelines are our compass, but in urothelial cancer, the landscape shifts faster than the map. We have NCCN, AUA, EAU, ESMO, ASCO, and national frameworks. Yet, drug access, infrastructure, and patient factors mean no two centers apply them the same way. Tonight, let's dig into how we use, adapt, and sometimes challenge guidelines in 2025. So first topic is which guideline drive practice? When NCCN, EAU, and ESMO differ, which wins in your clinic and why?
Yeah, we use these guidelines, the EAU, AUA, and also in Japan we refer JUA guidelines. But I think it's not practical to stick to just one set of guidelines. We usually mix depending on the patient context, and we use various guidelines for situations.
Okay. And in Japan, we have JUA guideline.
Yes.
Do you always use JUA guideline?
Maybe always, maybe. For me, the priority is high. JUA guideline is most high priority, but it depends on clinician. I'm not so good at English, so I often use JUA guideline.
Okay, thank you very much.
Thank you.
Next topic is, do guidelines dictate access? Do guidelines simply advise, or do they decide what's available?
So in many countries, reimbursement is tied to guideline inclusion. And so, for example, the NCCN guideline is often required for the insurance coverage, but the EMA approval is not same. So the EMA, so national reimbursement there is 6 to 1 year. So it's depends on the guideline. So in Japan, the guidelines currently updates annually, and these guidelines generally requires insurance coverage. But these guideline shows only for the not standard situation. You know, the problem is there is some equity gaps. You know, the rural centers or the low volume centers, they may lack some these novel diagnostics and some endorsements.
Okay. Have you had to use outdated regimens because reimbursement lagged?
Actually, yes. Some hospitals, yes, I think so.
But recently, such a reimbursement lag has become shorter than previously.
Yes, I think so.
Yeah, in Japan, approval process is faster than compared with previously.
Yeah, but still slow, I
Yeah.
think.
Okay. So next topic is too slow for science. Do you wait for guidelines or move ahead of them?
I personally move ahead. I want to move ahead. However, in clinical practice, the reimbursement and approval are very important. In Japan, guidelines are used as a tool for doctors and patients to determine the optimal treatment. Consequently, treatment recommended in guidelines must, as a rule, be covered by health insurance. On the other hand, we urologists also need to be aware of world's most advanced treatments. Japanese urologists, for example, refer to guidelines such as the NCCN guidelines. So it would be beneficial if the NCC guidelines included a fast track section.
Mm.
Mm.
Yeah, in Japan, our guideline, Japanese guideline, does not have a fast track section, and so how do you think should guideline include a fast track section for emerging data? How do you think?
Yeah, it's better to add fast track section, but it's very difficult because it takes a long time complete new guidelines based on the method of so-called MINDS and the Japanese rule.
Yeah,
That's why it's very difficult.
yeah, I also think so. Okay, so this is one topic, sacituzumab govitecan, from adoption to withdrawal. Sacituzumab govitecan was embraced quickly for post-platinum, post-IO MUC, and just as quickly it's gone from the US label. What happened and what do we take from that experience?
Yeah, Sashitsuzumab is difficult to pronounce, so I will say SG. SG
Yeah.
was never approved in Japan, so we didn't experience this withdrawal issue. In Japan, our regulatory process is relatively slow, so in Japan, such scenario is less likely due to our drug law. So maybe such situation is rarely happen in Japan.
Yeah. As you mentioned, in Japan, we have no accelerated approval system.
Yes,
But
yes.
yeah, uh, after SG, are you more cautious about accelerated approvals?
No. We need maybe we don't need to care about that in Japan.
Yeah. Okay. So we don't have to care. We have no such accelerated approval system.
Yes, I
Okay.
think so.
Okay. And okay. Do guideline match real patient? Next topic. Do current recommendation fit the patient we see we in front of in front of us? How do you think?
So the answer is yes and no, because these recommendations, many of them are shown fit only for the comorbidity-free patients, and but in our actual practice, so there is many patients with some comorbidity or the severe comorbidity. So these gaps we should think about because this does not fit for the recommendation by the guidelines.
Okay, so should frailty score be mandatory in UC guideline pathway? How do you think?
Actually, I think yes. The priority scoring and also the geriatric assessment is mandatory. But in our actual practice, I do not all of them. So
Yes,
we should do that.
yes, it's important, but we always do not do. Okay. Okay, next topic is what frustrates you most? What frustrates you most about UC guidelines and what would you change if you could?
Yeah. Please take a look at the everything. I think that everything written here is correct. I agree. And rather than being a floor or ceiling, guidelines should be regarded as a comprehensive reference covering all treatment that should be offered to patients.
So, do you think are guidelines a floor, minimum care, or a ceiling, limit innovation?
I don't know. I don't know. But I think that guidelines is not neither ceiling nor floor. Guidelines should include all treatment that should be offered to patients.
Yes. Yeah, in Japan, our system is like that. Yes.
Yeah.
Okay. I would like to wrap up this segment. Guidelines gives us guardrail, not autopilot. The art of UC care is knowing when to follow them exactly and when to adapt them to new science, real-world constraint, and the value of the patient in front of you. Okay, we'd like to move on to segment 4. Please, Professor Chan.
Thank you very much, Professor Ito and panel. I learned quite a bit, and we have a lot of similarities. I like the guidelines as you described, Dr. Kitamura. It's neither a floor or ceiling. It's a reference frame. It's a framework. Sometimes it's the minimum, and sometimes it says you shouldn't do things, but it gives us choices. It cannot be complete, but we would love for it to give us information for every single patient. So when Professor Inakuchi said about frailty and geriatrics, I am like you. I should do it more. I should do it every time, but honestly, I don't. But
Yeah.
as we try to get better care, I think we will learn more and more for sure. We're going to look now at actually side effects, adverse events of locally advanced and metastatic urothelial carcinoma therapies. And it's really important as we move into this field because we've got so many more treatment options that have so many more adverse events. But it's important because you need to keep your patients on for a period of time long enough for these treatments to work. So you have to manage the side effects. So we'll start off with Professor Inakuchi looking at adverse events. Are we doing a better job identifying? Do we know them? And tell us about some of the more difficult ones you've treated.
Actually, the IRAs. So we have many experiences using the IO. So we have many experience for the management for IRAs. But for example, the EV-pembro combination, they have another severe adverse events, and these are not common, and sometimes it's very difficult to distinguish which cause these adverse events. So we need to running about the management of AUs, and this for the EV panel combination, the pneumonitis, such as pneumonitis, is common between the IO and EV. So it's very difficult to manage and understand what happened and what we should do.
Tell me about tell me about your use of steroids, how you use and when you use and if it affects efficacy of the IO therapy specifically.
Actually, the steroids. So we should use steroids for the severe adverse events. That makes more treatment continuation. So that's a big point for the.
Yeah, I think that's important. You know, the use of steroids when used to control the side effects, there's no impact on the benefit of
Yes.
biotherapy. It's part of that therapy, so it's important to continue the therapy long enough, like I say, to get benefit. So,
Yes.
how about the more advanced grade 3 or higher adverse events? You know, tell us a little bit about what you do. Do you treat again? Do you give the IO again? Do you give a different IO? Perhaps Professor Yajima, your thoughts.
I
Yeah.
Or Professor
Ah,
Kitamura. Yeah.
Yeah. Please, Dr. Yajima, if you have comments.
no, I don't have special opinion. It's difficult.
Because
I would agree. It's
hybrid
always difficult.
AE, so
Mm.
we should perform the high dose steroid, and in that case we should quit. No, we should stop the IO treatment. Sometimes we can use, but yeah, it's very risk they have.
So
Yes.
as you consider things, let's think about we'll focus on enfortumab vedotin, the EV, because that really the one that targets Nectin-4, the one that we're using in combination with IO, with pembrolizumab most recently. You know, it's important that we continue, but clearly there are side effects. Clearly there's accumulation of toxicity. Tell us a little bit about EV and its side effects.
Yeah, neuropathy, for especially for using EV, neuropathy or skin rash are more common. And maybe neuropathy deserves special caution because it can be long lasting. So we generally follow CTCA grading when making decision about those modification or discontinuation. We need to early recognition and adjustment, especially for neuropathy. I think so.
No, really good point. That neuropathy needs to be found early, treated, dose limited, et cetera, because that neuropathy does not go away stopping the EV. So recognizing early, decreasing its possible accumulation is important. This slide also demonstrates the rash and the hyperglycemia. How about what about SG? I agree with you. I'd rather say SG than sacituzumab govitecan. So SG, tell me a little bit about side effects and use of SG in Japan.
Okay, so SG is not available in Japan, so we don't have any experience. So I don't know, but based on the trial result, the SG shows neutropenia and the diarrhea. So the ARI GCSF use is sometimes mandatory.
Yeah, I wouldn't spend too much time with
And
this. It's not available in Japan. We
yeah.
pulled it out in the US. Now, erdafitinib is interesting. We're looking at erdafitinib. We're actually looking at it putting in the bladder. We clearly some benefit has a target. What about erdafitinib? maybe Professor Kitamura, what do you
Ah,
think
yes.
about erdafitinib?
Yes, yes. We have to care some severe side effects in terms of erdafitinib. To date, I have not experienced severe ocular toxicities, but going forward, I intend to maintain a close liaison with my ophthalmologist, ensure we can address any ocular toxicity that as they arise. And as with ocular toxicity, attention must also be paid to nail changes. Nail removal may occasionally be necessary. Whether to discontinue treatment should be judged based on the balance between efficacy and side effects. I am wondering if Japanese or Asian patients will have more frequently nail toxicity than ITT population.
No, yeah, I don't know if we know the answer to that, but you can already see the differences in the side effects. So understanding each agent has unique toxicities, and this slide then asks, well, what do we do up front? Before we even start treatment, how do we decide? How do we prevent side effects? How do we look and do, Professor Yajima, maybe some strategies that you have?
If I have to choose just one preventive measure, I will focus on rash. Rash is common and it can appear early, and we can prevent it by appropriate skincare. So it's relatively manageable compared to other toxicities.
Well, do you, when you start teaching patients, when you start talking to patients about certain things, because they are probably the first, to tell you about something going on, they may disregard it, or they may tell you about things you don't want to hear about. Tell me a little bit about your discussions with patients regarding about what to look out for.
Actually, to patients, so we will explain these adverse events, and some adverse events rapidly worsen. So these symptoms we will explain and educate them to call us as soon as possible and come to the hospital. So this education is very important, I
No,
think.
I agree with you absolutely. There are a lot of very good slides that the AUA's put together. I think this is probably one of the most important slides right here about the side effects. We have differences in terms of what's available, what's not, what's approved, what's not. But clearly IO therapy, clearly EV, clearly the other medications that are targeting, they each have their side effects. And when they're in use, we got to know about the bad ones. And for IO, that diarrhea, the anything itis, the cough, the change in the liver, the hepatitis, those things they need to know about. And with EV, the neuropathy and rash, those are the two things I really focus on. And then any vision changes, the mouth sores, that type of thing with the FGFR3, the erdafitinib currently. So I think that's all very important. So if we look at patient education, excellent segue, because it goes next to lots of things that we have to talk to our patients about. And it's so difficult when we talk to our patients about prostate cancer or about bladder cancer, because we have so many options. It used to be much simpler when I was as young as Dr. Yajima. Hey, we have this and we have this, and that's all we do. Now we have lots of choices and discussions. So
Yeah.
if we think about radical cystectomy, and we think about diversion, and we think about different choices, Dr. Jiman, tell me a little bit about how you make or help a patient decide, hey, I'm going to have a cystectomy.
Okay.
I'm not. If I do a cystectomy, what kind of diversion? Tell me a little bit about that discussion.
Oh, okay, thank you. In Japan, as you know, there are many elder patients, and stomach care is especially important. For patients with who are not good condition, for example, lower geriatric age score, often struggle with stomach self-management. So I will offer Neo Brother for just for young patient and cognitive not having cognitive impairment. That's important. And for patient with low GA, I arrange home nursing support service before a radical cystectomy. They frail patients often cannot manage their stomach.
Yeah, I
And
think that,
yeah.
I mean, I think all those points are really important. I think we're much more careful with neobladders as we learn over time. Your cognitive point, I think, is very important.
All right. Yeah. New brother is more difficult because they need to avoid overfill. So they need to learn to empty your new brother regularly. So it's difficult for patient with cognitive impairment.
So then this slide then asks, how do you help the patients that may have little knowledge or little proficiency or not understanding? How do you help teach patients about what to do next? Maybe
Yeah,
Professor Nikuchi.
that it's a very big difficulty for us. So to use professional interpreters is a good way, I think. But this interpreters is not common in Japan, so we cannot use so easy. So, but technically, this teach back method is very useful, and using some visual documents using the pictograms or these very easy to understand method. So
And
very important thing is to avoid the jargon.
yeah, no, and so you have available in Japanese literature that you can hand to the patient.
Yeah.
Good. That my residents make fun of me, but I still draw pictures because I think it's helpful as you
Yeah,
try to
we
explain.
also doing these drawing the shamer or the yeah.
Yeah, no, very true. Tough topic here. Tough in that we are not very good at discussing this, I think, as a group, and actually many in the US are focusing on not only sexual health, but focusing actually on female sexual health that we've really tended to not discuss, not educate. So Professor Kadamura, your
Yeah,
advice. Tell us
it's
how you
difficult.
bring it up, how you
Yes,
discuss.
yes, I think it's difficult, but I discuss these methods with the patients at the end of the conversation about treatment complications. I expect they will be able to listen to them in a somewhat awkward yet natural manner. Although many Japanese patients do not consider sexual function to be important, it's a little bit different from the United States. We provide a comprehensive explanation of any potential complications related to sexual function that may arise after surgery.
No, I think that's a very good point. When you ask all patients, many are not, don't put that primary. But there are definitely patients that do, that we haven't done as good a job teaching. And so I think recognizing it on a caregiver part is really important as we go next. So a very important word, at least in the US, is this survivorship. So we've gone from, well, diagnosing and then treating, and then everybody wants to get to this point of survivorship. So any one of you tell me what is the overall survivorship plan? What do you do? How do you do it? What do you emphasize?
To be honest, I don't have special survivorship plan, nothing. But one thing we always emphasize is stop smoking if the patient have the habit. It's good for blood cancer and also good for their life. So patients with who are smoking, I always say stop smoking. Maybe that's the only survivorship plan.
Along those lines, taking care of all this in the US, we're fortunate at some large cancer centers where it's not a lung cancer clinic and it's not a breast cancer clinic. It's a survivorship clinic where actually survivors of all different kinds of cancers will meet and talk about physical training, diet, sleep habits, screening for other cancers. So it's something that psychologically I think is very beneficial as people get beyond their cancer diagnosis. At least for us, as patients get through their initial diagnosis or they get it, they go to the internet all the time. They try to get information. So, and sometimes they come in with a notebook and have everything, this is what, tell me in Japan a little bit about what you all do about the online information or wrong information. What do you do? How do you counsel these patients?
Yes. Actually, there are dubious clinics where that patients are treated with dubious immunotherapy. And also there are many supplement treatments. And these are not only offered as treatment for bladder cancer, but also for other cancers too. I believe that we should explain the treatment listed in the guidelines to patients and make them available as discussed earlier.
Yeah, no, I think that point is really important. It's that, we're responsible as we wrap this session up. We're responsible to provide the accurate education and being able to then tailor that education to the particular patient. One may have lots of information, one may be very limited. Understanding the cognitive capabilities, as Dr. Yajima mentioned, I think is very important because we want to offer therapies, but we also want to be able to understand that we want to protect the quality of life. So, we've gone through a lot. We've gone through diagnosis and evaluation, risk stratification. We've gone through treatment strategies, how we incorporate the guidelines. We now have gone into treatment options, survivorship, side effect management, etc. And so hopefully we've been able to answer some of the questions that individuals may have. So I really want to take this opportunity to thank Professor Ito and all my Japanese colleagues who really showed their knowledge, their experience, their wisdom and their honest opinion regarding integration of these more advanced treatment options. I think very, very much that this is really an exciting time for urothelial carcinoma, but just as importantly, it's a very, very exciting time for the AUA working with the JUA in this collaboration. So I want to thank all of you all for participating, and want to thank obviously our Japanese colleagues and all our folks at the AUA who helped put this together.